This is my presentation on typhoid fever. I'm Ashley Lukasak. Today we're going to focus on typhoid fever, a bacterial infection originating from the bacteria Salmonella typhi that is estimated to cause 200,000 deaths worldwide. Notable with symptoms of fever and septicemia, it is usually transmitted via fecal-oral route, emesis, or oral secretions. For now, we'll discuss the transmission method of the fecal-oral route. This indirect disease transmission is a biologic, vehicle-borne infection that occurs with water or food contamination that is consumed orally. Upon consumption, it enters the gastrointestinal tract and infects the host biliary tract, lymph tissue, ileum, and colon. Considering the world's population acquired from the United States Census Bureau at the time of this presentation preparation, and an incidence of 21 million cases reported worldwide, incident rate can be estimated at 0.26%. Estimation of prevalence versus incident rates is difficult to determine from available data, as this illness is able to be treated. Considering that this infection tends to affect populations with poor sanitation and safe drinking water, if estimating local prevalence rates, it would be much higher in that population to the point of being classified as endemic. Again, utilizing the same world population, mortality rates for typhoid fever can be estimated at 25 deaths per 100,000 persons. Per Taber's Medical Encyclopedia, within 1 hour of consumption, gastrointestinal symptoms may show up, but typically will subside prior to other symptom presentation. Fever is known to increasingly rise upwards to 104 degrees Fahrenheit. Additional signs and symptoms include anorexia, malaise, myalgia, headache, and slow pulse over 7 days, which is traditionally followed by evening remittent fevers and additional symptoms that may occur, including rose-colored abdominal rash, abdominal pain, diarrhea, constipation, chills, sweats, cough with moist crackles, abdominal distension, tender abdomen with enlarged spleen, and delirium as the bacterium leads to septicemia. Persistent fever, weakness, and fatigue continue to increase after 14 days, but should dissipate after 21 days. Additionally, gastrointestinal ulcers, abscesses, and intestinal perforation can lead to internal bleeding. In 10% of situations, this infection can be complicated by thrombophlebitis, pneumonia, septic arthritis, osteomyelitis, meningitis, myocarditis, cerebral thrombosis, or acute circulatory failure. It is important to note that this infection can relapse. The bacillus usually takes 6 to 30 days to incubate and is treated with antibiotic therapy, oftentimes using azithromycin, carbapenems, ciprofloxacin, and ceftriaxone. An emerging concern with this condition is the presence of many antibiotic-resistant bacterial strains. Only living in humans, this infection is rare in developed corners of the world. It primarily causes endemic concerns in areas where the living environment is unsanitary, hygiene is poor, and water is not safe to drink. Many areas of southern Asia, such as India, Bangladesh, and Pakistan, are included in this. Those that travel to areas of high risk within 30 days are at risk of developing typhoid fever. Prevention is essential, which consists of vaccination and safe eating and drinking habits, such as drinking either bottled water or water that has been held at a rolling boil for at least 1 minute, avoiding raw fruits and vegetables that cannot be peeled, and washing hands with soap and water prior to eating. 2016 data from the Centers for Disease Control and Prevention show that the median average age for infection is 23 years of age. Minimal demographic information is available on differences that were shown in the surveillance records, as the commonality is within the populations amongst unsanitary conditions. In a 2018 article in the Journal of Infectious Disease, social determinants of health that increased exposure or risk include literacy level, low literacy level that is, having a low to medium socioeconomic status, religious beliefs for treatment and prevention, and resistance to behavior changes. Some members of the study population opted to go to a shaman prior to receiving medical care or related illness to weather changes. Boiling water for safety was suggested, but participants discussed that much of this resistance to boil water comes from rationales of laziness, insufficient gas to be able to boil the water, dislike of the taste of boiled water, and feeling that it is not necessary to boil water after not needing to do so for an extended period of time. The literacy rates of the population may lead to not seeking medical care, in addition to the financial cost it takes to pay for treatment, care, and travel to the medical facility. Many of the population live in rural areas, which, coupled with low socioeconomic status, can be challenging for care. The living environments are not clean, nor is the hygiene, and the people do not always understand the need to improve these conditions, as well as having an increased rate of exposure to others that are suffering with typhoid fever. According to the World Health Organization, countries that are still developing have higher risk for exposure to Salmonella typhi, as antibiotic availability may not be as readily available and living conditions are poorer. Those that are vulnerable populations, such as children or the elderly, can be more sensitive to illnesses, and those of lower socioeconomic status and rural living environments have even more disparity as their access to treatment is severely limited. If symptomology and travel history are like that of Salmonella typhi infection, Salmonella typhi for a diagnosis of typhoid fever, diagnostics is confirmed through a culture of a sample of the blood, stool, urine, and/or bone marrow, the most sensitive to these being the sample of bone marrow. Vaccinations are available both orally and injectably. Oral vaccinations are for those 6 years of age or older. Injectable is available for those 2 years of age or older. It is suggested for travelers to vaccinate for typhoid fever 2 weeks prior to traveling if using the injectable form, 1 week prior if utilizing the oral vaccination. While the vaccination is not always 100% effective and loses potency over time requiring boosters, a combination of vaccination and safe eating and drinking practices can help to prevent infection. Current hypotheses in regards to typhoid fever include showing that it can be spread through numerous avenues: foodborne, waterborne, and person-to-person, although fecal-oral spread is quite common. This can occur through either sewage exposure to food and water or improper hand hygiene in the presence of ready-to-eat food. It is assumed that vaccines can improve the rate of infections. If vaccines can be prioritized to areas of high risk, this may reduce the need for antibiotic use, which would ultimately help to prevent further creation of extreme drug-resistant bacteria. Lastly, education on disease prevention is essential to control the attack rate of typhoid fever. Current gaps in the knowledge include looking at the development of extremely drug-resistant typhoid fever treatments of azithromycin and carbapenems have been shown to be effective. However, in severe cases, additional antibiotic treatments may be needed requiring assistance from infectious disease providers. Continued research should be completed to find more treatments for this, as well as the best prevention from creating more resistant strains. Additionally, a large gap in the knowledge would include how can healthcare access become more readily available for those in rural environments? Are there ways to improve barriers in regards to transportation and financial access? Also, some prior patients that have had typhoid fever are temporary carriers versus chronic carriers, which are those that shed the infection over a greater period of time, so greater than 12 months. We would really benefit from having a better understanding of how this temporary versus chronic condition comes to be. Recommendations that I have to address typhoid fever would include finding some ways with adequate funding that may be able to address gaps in typhoid fever knowledge, including making mobile clinics that would allow access to rural regions without those patients needing to pay for transportation or housing, in addition to the medical care costs, as well as prevent potential further exposure to other persons well infected from those persons having to travel and stay in public areas. For those that are planning to travel to areas that had higher level of development to lower levels of development, they should be offered and provided with more education on vaccination and the importance of following preventative methods. This could potentially be done by making these resources more readily available at points of airfare, primary care offices, hotels and places of travel, as well as travel websites or with travel agents. With low literacy rates proving to be a barrier to typhoid fever prevention, it is imperative to make education resources that are more understandable for those of lower literacy levels, and that may include higher ratio of images to words or hands-on education to make prevention methods more attainable and understandable for this population. Suggestions on further research. Information that would be beneficial to research would be further data collection for epidemiological analysis of demographics of those that are infected with Salmonella typhi, as this is not largely available. Also, further investigation into bacterial genetic mutation that leads to antibacterial drug resistance would be helpful. What makes these strains different than the standard strain? What is causing the resistance? Inadequate completion of antibiotic regimens? What other rationale? Implementation of evidence-based prevention or intervention programs. Upon phase 3 clinical trials of conjugate vaccination in Nepal, it was found that vaccination proved to be effective in those ages 9 to 16 years. There has also been a revised global vaccination policy that has reviewed current vaccination efforts and the issues that arise from antimicrobial resistance. This study suggests that funding should be made most readily available for high-risk infection areas to have access to vaccination to try to reduce illness in the population and provide further education on how important safe water and sanitation practices are in the prevention of illness and reduction of risk of death associated with typhoid fever. These are just my references. Thank you for watching, and feel free to comment if you have any further questions.